This topic is positioning. Let's start off by talking about the Fowler position. There's 3 different types of the Fowler position. They all share the same idea that the patient is lying on their back with the head of the bed elevated to some degree. The semi-Fowler position specifically has the patient elevated to 30 to 45 degrees in the bed. This position is helpful because it allows for expanded lung capacity, particularly in conditions like cirrhosis of the liver or ascites where we have an increase in abdominal girth. This increase in abdominal girth puts pressure on the diaphragm, and that makes it harder to breathe. So as you set a client a little bit higher in the bed, it gives the diaphragm a place to drop, the lungs have more capacity to exchange oxygen, and it makes them feel better. Another important indication for this position is restraints. It's hugely important with restraints that we be careful about preventing aspiration. And so one of the ways that we can support this is by putting someone in a head of the bed elevated position, because if they happen to have secretions pooling in their mouth or they vomit while they're laying down flat, they're not going to aspirate on it. Another indication for semi-Fowler position is in the postoperative client, particularly procedures like thyroidectomy or mastectomy. There's a potential for swelling up around the airway. And so having a patient sitting up allows gravity to help remove some of that edema and move it down to help protect their airway. Additionally, patients who are postoperative have received a lot of medications, and a lot of times they're experiencing nausea. And so with the potential of them vomiting, we definitely want to put them in a position where we reduce the risk of aspiration. Next up is the Fowler position. So similarly, the patient is lying on their back in the bed. The degree that the bed is elevated is increased to 45 to 60 degrees. So this achieves the same objectives as the semi-Fowler position, but it has an even greater angle. So it has an even greater capacity for improving oxygenation and reducing discomfort. Also, this is just a pretty common position that patients lying in while they're in the hospital, like watching TV, chatting with family. This is a pretty common position. It's always helpful to support them under the knees with a pillow, of course, behind the head, and the lower back too is a great place to support with a pillow. Next up, we have the high Fowler position. Just like the others, the patient is lying on their back, but at this point we have them elevated pretty much as far as the bed can go. The angle is 60 to 90 degrees. It's more like sitting up in a chair. This really maximizes the opportunity for lung expansion, which promotes oxygenation, and its indications are more acute situations like dyspnea, called shortness of breath, and then chronic respiratory conditions, because this really is just targeted at improving your oxygenation. The tripod position achieves a similar outcome of facilitating lung expansion, but in this case, the patient is in a position where they're leaning forward and they're putting some of their body weight on their elbows, often on their knees. And leaning forward in this position helps. Again, gravity is doing some of the work here. Gravity is taking the contents of the abdomen and allowing them to go even lower. So here we're doing our best to just facilitate as much as possible to expand those lungs and improve their oxygenation. Not only is this a position that we would place the client in, this is also just a finding that someone may have if they're having a COPD exacerbation, they're having a really hard time breathing. Sometimes it just feels natural, like sit down, lean forward, put your weight on your knees. It just feels natural to them. So if you're seeing your patient doing this when they weren't before, that could be a sign that they're worsening in a respiratory condition. In addition to COPD, asthma is also a condition where you could see this, that a patient would use this to improve their lung expansion. The orthopneic position is intended to achieve the same outcome, but instead of having the client seated in a chair, the client's in the bed, and we allow them a place that they can support their upper body weight with something like their bedside table. So here you can see in the image, the patient is leaning forward, putting part of their body weight on that bedside table. We've placed pillows there for their comfort as well, but this achieves the same outcome of just putting some of their body weight somewhere else, leaning forward, allowing gravity to take the abdominal contents away from the diaphragm, and offering more opportunity for lung expansion. The Trendelenburg position, this is more of a procedural position. This is not a position you would normally put your patient in during the day. This is something they do during an operation because they need better access to maybe the lower abdomen. Again, if you put your patient in a position where their feet are higher than their head, gravity is going to pull the contents of their abdomen downwards. And this could give you better access to like the pelvic area if you're doing some sort of procedure there. But because of this, there are contraindications such as neurological conditions, because as gravity is pulling the abdominal contents down, it's also pulling down other fluids like cerebrospinal fluid. And so if you have additional cerebrospinal fluid influxing into the brain, then it can increase your intracranial pressure, your ICP. Patients who are already experiencing a neurological condition like a brain injury really need to be careful about not having additional increases in ICP. So that's a contraindication for putting someone in the Trendelenburg position. Additionally, you would not want to place a client in the Trendelenburg position if it's someone who has ascites or some other condition that will be exacerbated by the abdominal contents pushing downwards on the diaphragm and again, decreasing the amount of room you have to expand your lungs, because doing that, taking that space away from them, it will exacerbate their shortness of breath or dyspnea. And so we want to be really careful that some patients just can't tolerate this position. You'll also see healthcare workers at times use this position just for adjusting a patient in the bed. So they'll have a lift sheet under the patient and they'll let gravity do some of the work of taking the patient and lifting them upwards in the bed, maybe before a meal or something like that. But again, this is the opportunity for the nurse to say, hey, this patient's not a candidate for putting that position. So this is an important safety concern. The reverse Trendelenburg position, pretty obviously, it's the same as the previous one, but we're tilting in the opposite direction. At first, you kind of are reminded of the Fowler's position because the feet are lower than the head. But the difference is that the Fowler position involves the mattress itself bending to sit the patient upwards, whereas the reverse Trendelenburg position, the patient is flat, but the entire bed is tilting. This position is used more in specialty scenarios. For example, someone that had a head and neck or spinal condition or post-surgical. Additionally, someone who had a femoral artery approach for cardiac catheterization. It's a very dangerous complication after cardiac catheterization that they can have a bleed if that clot doesn't stay. So we tell them, we're very firm that if you have that femoral access for cardiac catheterization, we tell them you cannot bend at the waist. We want them for a certain amount of time to stay in one place to make sure that clots and they don't end up having a bad bleed. So the reverse Trendelenburg position can allow them to stay flat like we've prescribed them to do, but sit up, but have their head elevated a bit, which makes it easier if they want to drink some ice water after their procedure. So that may be another time when you would see reverse Trendelenburg used. One piece to be aware of is that this could be contraindicated if someone has a circulatory condition like venous stasis in the lower extremities or peripheral edema. This will worsen those conditions because gravity is going to pull the blood downwards. So that would be a contraindication. The shock position is a modified version of the Trendelenburg position. It achieves the same idea of the feet moving above the client's head. Here, the idea is that we allow gravity to take the blood from the lower extremities and move it more towards the center of the body. This can help in conditions like hypovolemic shock because there's this sudden loss of blood that is causing hypotension. So as we pull blood more to the central circulation, we can correct that and improve the blood pressure by using the shock position. This is important because we really want to focus on perfusing the vital organs like the brain and heart and other parts of the central body when someone's experiencing shock. The left lateral Trendelenburg position, this one is another modified Trendelenburg position. This one is very special. It is reserved for emergency situations in which you suspect an air embolism. The idea here is that we can trap the little bubble of air against the heart wall. You can see in the image here where it's kind of stuck against the heart wall due to gravity, and it's preventing that little bubble of air from moving forward through the pulmonary artery, which is very dangerous. If it moves through the pulmonary artery, it's going to get into the lungs. It would block blood flow to the capillaries, which are essential for oxygenating. It could also move somewhere else in the body. It could end up in the brain. It would cause ischemia because, again, you're having air trapped where there should be blood flow to perfuse the tissue. So if you see this position, it's because you're suspecting an emergency is happening, and it's temporary. We would wait until that air bubble was suspected to have dissipated or some other intervention was performed. The supine position, this one is one of the most basic positions. The supine position means that you are on your back. People generally always use this word to mean they're on their back and they're flat. So when you hear supine position, you think they're on their back and they're flat. Indications for this would be a spinal surgery, or again, like we talked about, a femoral artery cardiac catheterization. This is the position they maintain patients in afterwards because we're trying to protect that surgical site from breaking a clot and bleeding, which can be very severe when they access that artery. So you would maintain this position for the client for a certain prescribed amount of time after that procedure to protect that site. But be careful to consider that when a patient is lying flat in this way, they are at an increased risk of aspiration. So when you go in there and provide fluids, you need to be careful about making sure they don't aspirate. The prone position, just the opposite of the supine position. The patient is turned over and they're on their abdomen. There's a few indications for this. You don't see this position very often, especially working in the general hospital area. But it is used after a lower limb amputation to prevent hip contractures. After the amputation, the hip wants to flex, but we place them in this position to help encourage the hip to remain in an extended position so you don't get a contracture. Another indication for this position would be acute respiratory distress syndrome. We call that ARDS. When a person is experiencing ARDS, they have this severe injury to the alveoli in their lungs that makes it very difficult to oxygenate. So as much as we can help support the alveoli in staying open, we can help support their oxygenation as they are in this very, very critical illness. This patient in ARDS is definitely going to be in the ICU. So to help open up some of those alveoli that may be starting to get closed, especially if you're laying in bed for days at a time because you're critically ill, the alveoli at the back of the lungs, due to gravity, may be collapsed. So we can flip them over into the prone position and allow gravity to move some of the fluid and let those, the small balloon-like alveoli kind of pop back open again, which is helpful for improving oxygenation. So they help to do this by putting them in the prone position, but then they go back and forth. They rotate them from prone to supine to continuously support the alveoli function here because oxygenation is just so difficult with these critically ill patients. The Sims position is most often indicated for interventions or procedures. For example, a very common one is enema administration. Helping the client into the Sims position not only gives the nurse easier access to administer the enema, but it also, with the change in the pelvis angle, it helps the fluid that enters into the colon to be retained more easily. It eases the flow of the fluid into the colon. So this improves the successfulness of the enema. If you can do it in the Sims position, it'll help. It is also helpful at times in alleviating some of the referred shoulder pain that occurs after laparoscopic surgery. When you have a laparoscopic surgery, they enter your abdomen through small incisions, and gases are needed to help inflate the abdomen a bit so that they can have a more easy visualization inside, so that those gases that enter your abdomen can sometimes cause pain afterwards as they irritate your diaphragm. And so irritation can cause that phrenic nerve to become painful, and it will actually refer the pain that's really caused by something in your abdomen, it will refer it all the way up to your shoulder. And that can be scary for patients because they're like, shoulder pain. Sometimes you think of maybe a cardiac arrest with shoulder pain. So it's a little scary. It feels kind of random, but the Sims position can help with that. It can help relieve some of that irritation. The lithotomy position is more of a procedural position. It's used for procedures like pelvic exams or cervical dilation, or part of the urinary system. They could perform a cystoscopy to look at the bladder, and you would want to have your patient in this position to give you better access to the pelvic area.